Thank you for joining the premiere of Inflection Point, the Go Red for Women Venture Fund webinar series. I'm Tracy Warren, Senior Managing Director here. This fund was established last year thanks to the generous support of the American Heart Association and Sally Soter. Inflection Point explores new frontiers where science, investment, and innovation intersect to elevate the health for women. Today, we're discussing small vessels, big breakthroughs, the next billion-dollar cardiovascular market. It's my pleasure to introduce Dr. Harmony Reynolds and Jyoti Gera, who are here today to share their insights on the opportunities created by the prevalence of non-obstructive coronary artery disease, particularly among women. Dr. Harmony Reynolds is the Joel E. and Joan L. Smilo Professor of Cardiology at the NYU Grossman School of Medicine, where she directs the Sarah Ross Soter Center for Women's Cardiovascular Research and co-directs the Cardiovascular Clinical Research Center. Dr. Reynolds was particularly well known for her work in myocardial infarction with non-obstructive coronary arteries, MINOCA, and stable ischemic heart disease with non-obstructive coronary arteries, INOCA. Her clinical efforts focus on cardiovascular disease in women and the problems that disproportionately affect them. Among many recognitions, Dr. Reynolds is recognized as an exceptional woman in medicine, a top doctor by Castle Connolly, and named an A8 American Heart Association founder affiliate rockstar of science. Jyoti Gera is CEO of Cardiovascular and Interventional Solutions at GE Healthcare, where she leads the company's cardiology vision across care pathways. A medtech leader, Jyoti has been instrumental in delivering innovation and driving business growth in GE Healthcare's cardiology ultrasound, breast care, primary care, and handheld ultrasound business units, including impactful AI-based innovations and the launch of vScan Air, GE Healthcare's first wireless handheld ultrasound device. Over her career, she's led anesthesia, ventilation, and monitoring subsegments globally, and has expertise in working with various healthcare enterprises, fostering GE Healthcare's partnership with startups, research institutes, governments, ministries of health, societies, and healthcare associations. And now, please join me in welcoming Dr. Harmony Reynolds and Jyoti Gera. Dr. Reynolds, would you set the stage for us about non-obstructive coronary artery disease? What are the various forms? What are the biggest clinical challenges? And what are the emerging solutions that you're seeing?
Well, thank you so much. It's really a pleasure to be speaking here today, and I very much appreciate the focus on heart disease that disproportionately impacts women. So I've prepared a few slides to answer all those questions, and let me go right into that. These are basically the types of heart disease that we didn't learn about in medical school. I teach them now, but the people who are coming up even recently don't know exactly about this type of heart disease, and that's something that we need to fix. We were trained, in contrast, to think about cardiac chest pain in medical school as this is who it affects, and this is what it is. So it's the disease of older white guys, and it is, let me just switch my pointer again, and it is something that is caused by artery narrowing from cholesterol plaque, as you can see in this schematic. And this is the most common cause. It's just not the only cause. There's more to blood supply than large arteries. In this schematic of a chunk of heart muscle, you can see that the big feeder arteries that we pay attention to, like the one I showed you on the last slide, they ride on top of the artery. That artery rides on top of the muscle, and it gives little arteries that dive into the muscle to make sure that there's blood flow to every area of the heart. Chest pain, blood flow mismatch, and even heart attack can occur without severe narrowing of those arteries on the top that we call epicardial coronaries. When that happens without heart attack, we call it ischemia or angina with no obstructive coronary arteries, INOCA. And when it happens with a heart attack, we call it myocardial infarction with no obstructive coronary arteries, or as I usually say with the patients, heart attack with open arteries. The causes of these are variable from person to person, but INOCA and MINOCA, they share some mechanisms. The diagnosis and treatment require further testing in both situations. and both are more common among women. In order to get into this, I want to make sure that everybody's on the same page about what the difference is between angina or angina, both are correct pronunciations, and heart attack. So angina, cardiac chest pain, is caused by a temporary mismatch between the heart's demand for blood flow and the amount of blood supply available. That mismatch is called ischemia. And this is the most common cause. It is plaque buildup within an artery. And you can imagine, as you look at this, that there might be enough blood flow. There's a lot of redundancy in health systems, in biologic systems. So you don't need the whole artery to be filled with blood in order to get enough blood flow to do the heart's work at rest. You can have that artery narrowed even 80% of the way before you might notice anything, even with exercise. But you can also imagine that when the heart's demands increase, this might not be enough of room in that pipe, so to speak, to allow an increase in blood flow to meet those extra demands. And when there's that imbalance, we call that ischemia. Acute myocardial infarction is something different. It's death of heart cells due to compromise of blood flow. The biochemical marker of this is troponin, and it manifests with symptoms, changes on the electrocardiogram, and abnormal heart movement. So there's an area of the heart that may not be contracting normally and doing its pump function. When we say MI is acute, we mean that something has changed abruptly, and now there's not enough blood flow to meet the heart's demands at rest. And again, the most common cause is atherosclerosis. So in this schematic on the right, you can see that just like before, there's a plaque there, but now something has changed. There's been a rupture in that plaque, usually at this area, the shoulder. And when the contents of that plaque are exposed to flowing blood, that blood will clot. And it can completely close the artery. And now there's just no blood flow at all. So clearly that's not enough to meet the heart's demands. If this goes on long enough, for 20 or 30 minutes or more, there's going to be death of heart muscle cells. And that is the typical type of heart attack. How do we look at this? Well, the test that's generally done to check whether the arteries are open or not is an angiogram. And this is an X-ray picture. So this patient is lying on an X-ray table with an X-ray camera moving around. And here, this shadow is the spine, this is the diaphragm, and here's the heart. And what we're seeing here, this line is the catheter that's brought up to instill the contrast liquid into the artery. And this part is the artery. At the site of the yellow arrow, that artery is totally closed. There's a small branch here, and then it's closed. So this would be a typical heart attack, and the treatment for that is balloon angioplasty and putting in a stent. And after that's done, you can see this artery was much larger. In fact, this branch that was catching our attention, that's this little thing here. So now we can see there's a huge difference in the artery. Again, that's typical heart attack diagnosed on an angiogram. Historically, most patients who don't have that kind of bad blockage on an angiogram, MINOCA, were told they were in the clear. So here would be a typical patient, 45-year-old woman. She's got a couple of cardiac risk factors. She has typical symptoms of heart attack, 30 minutes of chest discomfort, nausea, sweating, and she has an elevated troponin. So she meets our universal diagnostic criteria for heart attack. But on an angiogram, in this case, she only has a 20% narrowing, not nearly enough to limit blood flow in a way that we would think would cause heart muscle dysfunction. That threshold of significant or obstructive is typically defined as narrowing at least halfway, but in truth, you need a much greater narrowing in order to limit blood flow. How common is this? Well, 6 to 15% of heart attack cases are MINOCA, and the 15% figure is from women with the type of heart attack called non-ST elevation MI, the ones who are not rushed into the cath lab, and that's quite a common phenomenon. MINOCA is more common when we think of heart attack patients. It's more common among those who are women, younger, or people of color. Historically, these patients were told, hey, great news, your arteries are open. This can't be a heart attack. But that is not exactly right. And let me show you why. We know this because MINOCA can be fatal. The prognosis is not good. We showed that MINOCA could be fatal by working with the New York City Chief Medical Examiner's Office and examining autopsy records. 17% of people who had died under the age of 55 and had evidence of heart attack at autopsy had no significant narrowing of their arteries. And yet still they had a myocardial infarction, so that's MINOCA. The first of the large studies to chart outcomes in MINOCA patients is from Sweden, and it had over 9,000 patients with MINOCA. As you can see, the death rate over 4 years was 13% after an event, 7% had another heart attack, 6% had heart failure, and with a 4% risk of stroke, that's a 24% rate of major adverse cardiovascular events at 4 years. Now, this is less than in heart attack with badly blocked arteries, but it's not a good thing to have. It's certainly worse than never having heart attack at all. Why does this happen then? Well, one of the things that's been well described is that the coronary angiogram, though extremely important, is inherently limited because it only shows us where the blood is flowing and it doesn't show us the wall. And we've learned this because of studies using imaging that looks inside the artery. So here's an angiogram, much like the one I showed you before, and these two black arrows mark two spots that look really normal on this angiogram. When we look inside the artery, in this schematic of intravascular ultrasound, this you can ignore, it's just the imaging catheter. And this black is where the blood is flowing. This little bit is the wall, and everything outside it is tissue outside. And this artery measures the lumen, where the blood is flowing, measures 3 millimeters. And over here, this measures 3.1 millimeters. It's the same size, but we know that from the angiogram. What we see that's different is you can probably appreciate this whole big half moon thing. And all of that is plaque that is lurking in the artery wall and could potentially cause a problem. Not all plaque can be seen on an angiogram, as I just showed you, but also not all plaque rupture can be seen on an angiogram. So here's another schematic, and this is like a cross-section of an artery. This orange thing is the plaque. This yellow bit is the core of the plaque that we know is really prone to making thrombus, making blood clots happen. And if there's a rupture, as noted there, and you get a blood clot that looks like this, we would see this on an angiogram because there's only this little bit of room for the blood to flow. But if instead that blood clot were smaller, we might not see this on an angiogram because there's so much room for the blood to flow still. And yet this blood clot can break off. And as you can see in this schematic, it could lodge in a smaller artery. And then all of the heart muscle that artery serves could potentially die. And that's how heart attack happens with a ruptured plaque with only a small blood clot and a small plaque to begin with. So this is a mechanism of Minoka. And it's very similar to heart attack with badly blocked arteries, just sort of in a way in miniature. But Minoka is not one problem. There are multiple underlying causes, and they're each treated differently. So I just spoke to you quite a bit about plaque rupture, and plaque erosion is similar, although the contents of the plaque are different. There's another problem called coronary spasm, which I'll go into. Some people have blood clot without plaque. Some people have a problem called dissection, which is basically a bruise inside the artery wall, and rarely that's the cause of Minoka. And sometimes that initial old school doctor was right. Instead, it's not a heart attack at all, and additional imaging tests can show us there was really inflammation of the heart muscle that made it look like masqueraded as heart attack. Or there's this other problem, Takotsubo syndrome, sometimes called broken heart syndrome, or it goes by a number of other names, which is not considered heart attack, but can look like a heart attack. It matters so much because these things are treated differently. So here are the two most common causes of Minoka, plaque rupture and coronary spasm. And the treatment of plaque rupture is medications that limit blood clotting and medications that lower cholesterol because that's what drives the heart attack. But coronary spasm is when the artery muscle transiently goes into basically a cramp, temporarily narrowing that artery, as you see here, and it can even close the artery temporarily and cause a heart attack. That's treated with medications that relax artery muscle, calcium channel blockers, and nitrates. So we'd like to know which one we're dealing with. To figure out how common each of these things is in Minoka, we embarked on the Women's Heart Attack Research Program, which was funded by an American Heart Association Go Red for Women strategically focused research network, which at NYU established the Sarah Ross Soter Center for Women's Cardiovascular Research. Our research question was how common each underlying cause of Minoka is, and our methods were to use multiple modalities of imaging in 145 women with Minoka enrolled in the US and Canada at 16 sites. We found that 85% of the women overall had imaging findings that pointed to a diagnosis. 64% of the cohort had evidence of heart attack, whether on one test or the other or both. 21% had something entirely that was not heart attack and was not clinically expected. And those were myocarditis, mostly in Takotsubo syndrome. So they're treated entirely differently and not heart attack at all. We had hoped that the clinical and laboratory features would be enough to pick out which patients need this extra imaging and which do not. Unfortunately, that did not work out. There was no substitute for doing the imaging. Here are two women from the study, and I think that this is really illustrative because these are two women with similar symptoms, similar EKG changes, the same degree of troponin, and their angiograms look very similar. but the imaging that we did for the study looks entirely different. So here's case one. This is called optical coherence tomography. It's again taking a picture from inside the artery wall, but with much better resolution than we can get with the prior thing I showed you. So here's the imaging catheter. That's the wire, and this thing's just a shadow from the wire. You can ignore that. You might be able to discern that there are 3 layers to this artery. There's a thin yellow band, then a darker band, another thin yellow band. That's a normal artery with a normal lining, looks great. This MRI shows us the heart muscle, and white shows us where any damage may be. This is the left ventricle, the main pumping chamber of the heart. And the red arrows are illustrating for you where there are some white splotches. And they are, the things to know about these white splotches are that they are not in one coronary territory. So it would be impossible for a single blood vessel problem to have caused this degree of abnormality. And they just have an appearance because of where they're located in the wall of something that was not a blood vessel problem. So this case, we tell that patient, you never had a heart attack. This is something called myocarditis, often viral. You'll recover, and that is the end of it. You don't need the usual medicines for heart attack. This case looked very similar clinically, has a totally different look on the imaging. So again, here is the catheter, the wire, the shadow, and you can probably appreciate that you don't see that nice 3-layer appearance. You see a bunch of smudgy stuff here. And this red arrow is pointing to a crack in that plaque, because this smudgy stuff is all plaque with cholesterol buildup, and the light doesn't penetrate through well. That's why it looks smudgy. And on a different image, having pulled back a little bit, we see a blood clot on top of that plaque. So this looks very much like the schematic I showed you of the plaque that had ruptured and had a small blood clot on it. And sure enough, the MRI showed that the abnormality in the left ventricle is right here where the red arrow is, and that is a through and through full thickness area of heart attack. That area was deprived of blood flow because some of this blood clot broke off, and that area corresponds exactly to the end of that artery, and that's how that heart attack happened. So one of these patients gets typical medicines. This last one gets typical medicines for heart attack. The other one does not. And the imaging completely changed the diagnosis for the clinical team. So now what do we tell this woman? We've got the next patient who comes in with Minoka. What do we tell her? I've already mentioned to you that we're not going to say routinely, it's not a heart attack. So should we say instead, hey, you had a heart attack? Well, not necessarily, because I just showed you another case where there was inflammation, not heart attack. In fact, what we need to say is, I need more imaging to be sure. And that's the main contribution of this study. So put another way, the patients may look very similar on the outside, but when we look on the inside by using the proper imaging tests, we can sort out who has what and then treat accordingly. And based on this work and others, guidelines now recommend imaging and then treatment according to the underlying diagnosis in Minoka. But there's so much more to learn. We'd like to know if the causes of Minoka are different in women and men. Female heart attack patients are way more likely to have Minoka. Are the causes the same when men get it? Through American Heart Association's funding and renewal of the Soder Center, we're doing an expanded study that includes men and women. We'd like to know how biomarkers can help, because again, one goal is to avoid the need for this invasive and expensive testing. We've been collecting DNA, RNA, and proteins to help us learn more about mechanism. We're collecting these biomarkers in HARP, but larger sample sizes are needed. And a bigger question is why some small plaques cause heart attack and not others, because most of us on this call have some small plaques, and most of them are quiet. Some of them break and cause Minoka. Some of them progress over years to be much more plaque buildup and then may or may not cause a heart attack. Few plaques cause problems, and we need to know which ones are going to be the problems. So that's Minoka. Let me talk to you a little bit about those patients who aren't having heart attack, those with ischemia and no obstructive coronary arteries, or INOCA. This is an incredibly common problem. It's even more common than Minoka. There are 3 to 4 million people estimated to have this in the United States. Again, about 2/3 are women. In this case, the symptom severity and quality of life day to day is similar to or even worse than people with coronary disease. And as with Minoka, there's an increased risk of cardiovascular events in the INOCA patient. These patients go on a diagnostic odyssey. They come in with chest pain. It sounds like heart disease, and some physician will send them for an imaging test of the arteries, often a coronary CP, but could be an invasive cardiac catheterization. And the arteries look open. So then that doctor will say, okay, I guess it wasn't your heart. Now let's look somewhere else. Maybe it was heartburn. And these patients often, about 1/3 of them, will have an upper endoscopy. and maybe there's some reflux or maybe there isn't, and they get treated, but the discomfort that prompted the whole evaluation is not going away. So say, all right, I guess it wasn't that. Maybe it's asthma. Asthma can cause chest pain too. So then those patients go for pulmonary function testing, quite a lot of them. And at this point, when that's normal or the treatment doesn't work, again, now we've investigated 3 organ systems. And now people are hearing over and over again, well, maybe you're anxious, you're stressed. Yeah, sure, they're anxious and they're stressed. I'm anxious and stressed. But they get sent to the psychiatrist, and the anxiety medicine or antidepressants are not going to work for their chest pain. It's heart pain. So they will come and get more cardiac testing. And often there are a few ER visits in between here because this chest pain can be quite bothersome. So now everybody's frustrated. The patient is frustrated because the symptoms are still there. Nobody knows what's going on and they can't seem to fix it. The cost of the healthcare system is large. And the doctor's frustrated because we like to make people feel better and know what's going on with them, and we can't help. In a survey of patients who ended up with this diagnosis, 60% saw more than 4 doctors before they got an accurate diagnosis. And that's just the patients who got a diagnosis. Many are missed. But to be fair, this is hard. So why is it so hard? It's hard partially because the angina, the chest discomfort with INOCA, can be what we used to call typical, where it's reliably provoked by exercise. Every time you run up the hill to the bus, you're going to feel that symptom. And if you don't, you won't. But sometimes it's unpredictable. For example, it happens often in INOCA that pain comes unpredictably at rest. And we were taught in medical school that if that goes on for 20 minutes, it must be heart attack. And if you can't find heart attack, it wasn't heart pain. That's not so, actually, it turns out, for these INOCA patients. We were taught that the only reason for ischemia is atherosclerosis, and I've just described to you that's not so. Blood flow, in fact, is primarily regulated by the smallest branches of the arteries, the arterioles, not the large arteries. The main mechanisms of INOCA are coronary artery spasm and coronary microvascular disease. And first here, I'm going to illustrate for you spasm. So this is another angiogram. You've seen a couple of these now. And this is the left main artery. Let's focus on this one, the LAD coronary artery. The circumflex is over there. And then we give a medication into the artery called acetylcholine. And that is supposed to make the artery relax. But in susceptible people, instead, the artery muscle will cramp, and this is spasm. And I think even without having seen many of these, you can probably appreciate that all of these arteries are much smaller than they were to begin with. That is an abnormal response, that's spasm. When we give nitroglycerin, it reverses the effects of the acetylcholine, and now you see these arteries are nice and plump. So when we see this, and the patient had chest pain over here, we understand that chest pain was from coronary spasm. For coronary microvascular disease, I can't show you an angiogram because by definition, the arteries involved are too small to see on an angiogram. So the analogy I like to use with patients is that the arteries are a lot like a tree. They have big trunks, and then smaller and smaller branches. And just like with a tree, most of the action is at the twigs because that's where the leaves are in the tree. And when it comes to regulation of blood flow, most of that regulation is in these small arteries, the arterioles. We diagnose this problem based on measurement of coronary flow reserve, and that is the amount of increase in blood flow the arteries can provide when needed. Normally, we can increase our coronary flow by at least 2.5 times, and 3-fold or 4-fold is more normal. But some people can't, and then they have coronary microvascular disease. Now, I told you a whole long story in MINOCA about how atherosclerosis initially people thought that wasn't the problem because the arteries weren't badly blocked, but in fact, quite often it is the root cause. In INOCA, there is often mild atherosclerosis, but it seems not to be the cause based on research that we and others have done. So that's a different situation. There is dedicated testing for this, much analogous to MINOCA. If you look in a different way, you're going to find the cause of the problem. And that's the testing that I showed you, the coronary flow reserve measurement and testing for coronary spasm. In a prospective study in which all patients, as soon as they had their angiogram and had open arteries, went right into dedicated coronary function testing called CORMICA. Half of patients had coronary microvascular dysfunction with their INOCA. 17% had coronary artery spasm, also called vasospastic angina. 21% had both, and only 11% had none of this. Only 11% truly had non-cardiac chest pain in this study. So the overwhelming majority did have some objective evidence of a cardiac problem. But again, there's so much more to learn. We'd like to understand the molecular mechanisms of inoca, and studies are limited by lack of availability of tissue. In many other problems, we can just take a biopsy of that organ and then look at it under the microscope, subject it to testing. We don't do that with beating hearts in general. People have to be really sick for us to biopsy the heart. We can obtain blood vessel cells and use blood biomarkers, and that's some of the work that we and others are doing. We'd like to diagnose inoca more accurately. Again, the goal is to avoid the need for invasive and expensive testing. So we and others are investigating testing at home with blood markers, with ECG, and with the use of wearable. And we'd like to know the best treatment of this. Right now, we repurpose medications from coronary disease treatment, and they work variably well. Nothing is a slam dunk. There's no option here for stents to make people feel better. We're also studying non-pharmacologic therapies, like mobile-enabled cardiac rehabilitation. Looking forward, ischemic heart disease in women has varied underlying causes. It requires advanced diagnostics to get the right diagnosis, and we need new approaches to treatment and additional study of mechanisms. We'd like to identify MINOCA and INOCA subtypes without using all this expensive and invasive imaging. And we'd like to understand why some patients with small plaques that rupture have a heart attack, others progress to heart attack with closed arteries, and many are clinically silent. We need multidisciplinary investigation of extracardiac features that can cause inoca. We'd like to understand the interaction between the heart and the metabolism with skeletal muscle and systemic abnormalities of blood vessels. The goal is to bring forward these mechanistic insights into interventional clinical trials so that we can try and get people feeling better. And we're accustomed, of course, to leading those at NYU. So thanks again for asking me to speak about these problems that I think you can tell I'm really passionate about.
Thank you, Dr. Reynolds. I think you've done a great job of illuminating the diagnostic and therapeutic journey of these patients and some of the challenges and opportunities that hopefully our audience can resonate with. Now, turning our attention to Jyoti, you've deep experience in med tech and bringing innovations to life. Where do you see the potential for investment in diagnostics, in therapies or services to treat and address these non-obstructive coronary artery disease?
Thank you, Tracy. And that was just such a fantastic introduction by Dr. Reynolds. Super thrilled to talk to all of you today. And I just want to sort of build on what Dr. Reynolds shared with us. I mean, clearly what we are talking about today isn't just one condition like you saw, right? It's an entire spectrum of under-recognized ischemic heart disease that in a sense defies the traditional teaching, the traditional paradigms. So what I want to do is to just sort of talk through the current care pathways, just reiterate where the fallouts are and the opportunities are that were laid out so well just before, and then focus a bit on a playbook for market creation, right? What does it take to take an opportunity and convert that into an investable market? So if you can please go to the first slide on this one. Okay, this is awesome. Thank you. So let's just start with framing that opportunity that we just heard, right? I mean, clearly this is a very widespread condition. Collectively, they account for MINOCA and INOCA alone account for a significant and growing share of cardiovascular disease. And you saw some of the statistics, up to 70% of women with ischemic symptoms fall under the INOCA umbrella, and roughly 10% of MIs in women are actually MINOCA events, right? So these are patients, these are women like you saw presenting with angina, with ECG changes, sometimes elevated troponins. And if you rely on a coronary angio, sometimes normal coronary angios, right? And for far too long, this normal angio has ended the conversation, depending on where in the world you get into the health system with. But these patients, like you heard, are anything but normal. And clearly, we also frame this as this blind spot disproportionately impacting women, particularly young women. It's in healthcare, it's a cardiovascular health equity issue, clearly. And women are more likely to be misdiagnosed, right? They are just more likely to be told also that their symptoms are stress related, and the data backs this up. And you saw evidence from multiple trials here about just higher long-term mortality than we once believed, and a significantly lower quality of life for women that present with INOCA or MINOCA. And from a system perspective, I mean, the clinical failure here is clear, right? But from a system perspective, this is a cost center that is pretty much hiding in plain sight. Right, INOCA alone a particular study that's looked at the lifetime cost per patient, sized that at about $750,000 for a patient. Now multiply that by the millions that are affected, and we are potentially looking at over $20 billion spent annually in the US alone, right? And the global data is going to be much higher, all without a very clearly defined care pathway. Now, the good news, and which is why we are excited about this, and we are talking about this as an inflection point, is that the technology and the awareness are converging, right? You heard a lot of the opportunities that Dr. Reynolds talked about, advanced imaging, whether that is cardiac MR, whether that is PET perfusion, echo with CFR, and advances in AI, what we can do today, right? Whether that is automated AI-based quantification, just standardizing care, whether that is gender-based triage based on AI. I mean, we can make these conditions visible in ways that are more scalable than we could in the past. And clearly the culture is shifting. I mean, women are demanding more answers, clinical societies are rewriting guidelines, clinicians like Dr. Reynolds are really pushing hard to find solutions. And this unmet need now starts to frame itself to be the next potential billion-dollar market in cardiovascular care. And when you look at a parallel, whether it was AFib or structural heart that came before it, what we will need is an ecosystem to realize this opportunity. And the scale of the opportunity is going to be quite wide, right? Whether it's diagnostics, devices, digital tools, and ultimately just disease-modifying therapies that are precise, that are tailored to the underlying etiology of the disease. If you go to the next slide, please, what I want to do on this one is to just reiterate a little bit of what a typical care journey looks like, and think of this with a very global lens, right? With health systems all over the world that may or may not be the same level of maturity as some that you might be exposed to. And the way we frame this page is in a typical care pathway from a patient lens, right? It sort of starts with where the screening for a disease state happens, early detection, entry sometimes in urgent care, emergency care. How do you diagnose a disease? How do you escalate the diagnosis? Use multiple imaging modalities to what you just heard, treat and intervene, and then more importantly, follow up the patient, right? So when you sort of take INOCA and MINOCA and lay that out as this journey, I mean, you will see that there is the system could fall short at multiple steps here, right? And then the journey here could begin in the emergency room. It could begin in urgent care or in primary care if it was INOCA. And for a patient, for example, that comes in with INOCA, the diagnosis is very, very hard, right? I mean, they show normal ECG, sometimes normal troponins, inconclusive tests, and they are often sent through a battery of tests, and sometimes just in many parts of the world, they are discharged with no escalation to cardiology too, right? MINOCA patients, on the other hand, you could have like fully triggered MI protocols, etc. But if an angio shows no significant obstruction, in most places of the world, they wouldn't necessarily put you through the next imaging test either, right? The case could often get deprioritized. So the very first touch point with the healthcare system, now you see results in that clinical uncertainty, results in that mislabeling and a fallout potentially. Now, for those patients that do make it past the diagnosis, into the diagnosis phase, care could again be very, very fragmented, right? I mean, the patients will undergo routine stress testing, they will get a CT angio where it's relevant. In many cases, there is no reliable detection of the underlying microvascular dysfunction that you heard about. And then a MINOCA patient, again, there is variability in what you receive, right? You could get a follow-up cardiac MR. You could get a test to potentially assess for myocarditis that we talked about, but there isn't like a standardized protocol that escalates to the right advanced testing that is needed to determine what to do next. And often the patient journey could stall there as well, right? And then when you get into the therapy phase, you heard about, once the root cause is clear, right, there are therapies that you could exercise, but often it is not very precise. You could have treatments that are borrowed from obstructive CAD and applied broadly with very little precision. So there is a lot of room for innovation here. And perhaps the most concerning is the follow-up phase, because here is where, do we have a structured follow-up plan? I mean, these patients sometimes they suffer for years with persistent symptoms, with just utilizing healthcare. And you heard the number of visits it takes, and a very poor quality of life. And so the need for these registries, need for digital tools for follow-up, need for long-term tracking of outcomes is very, very visible. Enough said. So I think it's very clear that there is an opportunity here, but what does that mean for us, right? I mean, there is a clinical gap, there's potentially a structural void across this care continuum. And I think Dr. Reynolds framed it very well, right? When you think about what we can do in terms of really solving for this, there is opportunity just starting also with the early detection, right? I mentioned potential gender sensitive triage for frontline care, just making it easier to figure out what to do next, right? If you come in and you have a normal stress echo, as an example, can an algorithm recommend the next diagnostic to be done, right? If the symptoms persist, go to a CMR, go to an echo CFR as an example, or get a PET study next, right? So this access, this triage of what to do next is going to be super helpful to solve this problem at scale, right? The next opportunity, I think, really is to, a lot of the diagnostics we talked about, they're not democratized today, right? There is an access issue, there is a cost issue, there is a reimbursement issue. And I think that is the next big opportunity. How do we democratize that? How can we make sure that CMRs and PETs and echo CFRs are available? And importantly, automate the interpretations, right? So we can take the guesswork out of it. So we can scale them beyond the specialty centers that we see them in today, and get them to the secondary centers, get them into imaging centers, if you will. Huge opportunities for biomarkers that we heard as well. And then finally, I would be remiss if I didn't say that there was an enormous white space here to build longitudinal care models, right? Think about a single pane of glass across this entire disease state that goes through each one of these pillars, if you will. Build those digital platforms, the wearables, remote follow-up, and just all of this really leads to that reimbursement strategies that are based on outcomes based on this. And especially, the impact on younger women and this population that is digitally fluent. So I think there is a lot of opportunity there when you think about digital care models. So finally on this one, I just end with saying, look, the solution clearly has to be product per category here, but more importantly, an entire care model that eliminates that friction, that eliminates the dropouts that we see in the pathway. But if you go to the next slide, I mean, with that, let's talk about, a typical market creation playbook. And this is just insights that we've gained as G Healthcare from multiple efforts that we've done, as well as what we, the medtech industry and the pharma industry at large has learned over time as well, right? And you just see a few pillars that I've framed here. And I'll start with saying every market creation starts with a very clear unmet need. In this case, we've just discussed for INOCA and for MINOCA, the prevalence is high, the cost is high, poor outcomes, sometimes buried under diagnostic ambiguity. So I think the need is there, but what we need to do is to really progress that further with a very clear and compelling health economic framing, if you will, of this unmet need, right? And then it goes to, honestly, the next category there is any category creation needs a very measurable signal through diagnostics, right? And that's advanced imaging, non-invasive testing, AI-enabled tools, functional markers, if you will, that quantify disease, that predict response, etc. And reimbursed pathways for this diagnosis to happen, because if that is not reimbursed, it's not going to happen, right? So we have to measure, we have to build. And an example that comes to mind in this category from the recent past, I'd say, is FFRCT, right? What FFRCT does is to quantify functional coronary disease. It basically makes it possible to see physiology from anatomy. Now, this, even 10 years ago, this was very, very novel, right? And in 10 years today, it's guideline supported. It's a reimbursed tool that's making its way into the frontline very, very quickly. And there is perhaps a very similar opportunity that lies in the disease states we are talking about as well. The next lever, which I think is perhaps one of the more important levers, is education. And you see that happening across the board. This is education for clinicians, education for patients, the broader ecosystem, if you will. And here is where you really activate champions. And you heard from Dr. Reynolds, who's like a champion in this space, right? You build patient advocacy toolkits. And we create these partnerships with peer networks to really build that knowledge base, if you will. And if you want to change behavior at scale, every new category needs champions, right? So there needs to be that effort that comes in. In this area, honestly, the best example that comes to mind, because I was closely associated with that in my tenure in GE Healthcare, is really the movement around dense breasts, right? For years, women with dense breast tissue with normal mammograms were said everything is great. But we know that cancers were being missed, right? And when you think about the evolution of that, it took a massive push of advocacy, lots of patient storytelling, legislation, physician education, and to establish basically that dense breasts did need supplemental imaging, right? And today in the US alone, over 40 states mandate that patients are notified of their breast densities, and alternate pathways, an ultrasound or an MRI or other things are basically discussed with them. And perhaps we follow a very similar trajectory here, right? You have a normal angiogram, but you just have a high risk physiology beneath that. So that same level of provider education and guidelines, in fact, are very rapidly evolving in this area, but adherence to guidelines as well, patient-facing transparency to ensure that women aren't dismissed, right? When traditional tests say you're normal, but your symptoms say otherwise. So the next step in this playbook is also is what I call as codification. And codification is essentially where you get the pathways into guidelines, right? And you need very, very clear large-scale trials, and you heard many of them are ongoing with very clear both clinical and economic endpoints, right? So you need consensus statements, you need algorithms that are published, and this is when payers start to recognize the workflow and sort of start to have inclusion in CPT codes, right? And this legitimizes the category. And then think of what happened with TAVR, for example. And once CMS unlocked this national access, the pathway was codified and then the category was legitimized. And then that's sort of what it takes. And think about that in the context of what we've been talking about. And then finally here, economics and the care model, right? And the economics is straightforward. I mean, you have to prove the ROI, and often it starts with quantifying the cost of doing nothing, right? And then you build outcome studies, you build real world ROI data and make that case for cost effectiveness. And this is very powerful for payers, they demand it clearly, but also for value-based networks, for integrated health systems. They truly care about the downstream utilization, and we need to make that case, whether it is here are the ER bounce backs, or here is the long-term cost avoidance of doing something about this problem, right? And finally, I'll just end with the framework here with just, we have to rethink care delivery, that's sort of, if you solve for everything else, but if we don't solve for a system that's sort of designed to use the tools that are now rapidly evolving, you can't solve for this disease state. So you have to think about where a patient receives care, how a patient receives care, what is the infrastructure, what's the staffing model, what's sort of the clinical workflow in the patient experience, and how are we going to longitudinally manage this patient across the pathway. So that sort of needs to come together finally in this creation of this playbook towards the market. So if you go to the next slide with this one, so we've spent a lot of time on the clinical journey. We've mapped out like, what is this playbook, but let's talk about what it takes to drive anything into mainstream adoption, right? And this is, what you see at the bottom of this slide is like a very typical cross the chasm look. This is the chasm from early adopters to scale and to mainstream. And I must say many markets fail in this crossing the chasm, right? And this requires the ones that succeed, they succeed because of a very deliberate orchestration from this full set of stakeholders that you see on this page, right? And this could be startups. I mean, this could be startups that are essentially bringing the speed and the creativity into the field. It could be strategics like us that sort of bring the scale, we bring the ability to embed diagnostics into workflows. We bring potentially the ability to connect enterprise imaging across that single pane of glass, to partner with health systems in early studies and early trials, societies, KOLs, clinicians, payers, and policymakers that we talked about, right? And now this might seem very aspirational, right? You look at this and you're saying, oh, okay, this is a lot of effort, right? It's not just about the right technology. It's really about the alignment of these stakeholders, alignment of the incentives. And when you look at examples from the past, I mean, this is a cascade really that needs to happen. It doesn't necessarily happen in series. Often in the early stages of creating the market, you get this early momentum from some published evidence from very passionate KOLs activating the network, and largely academic centers that are driving this innovation, right? And then diagnostics become easier to use, they become more cost effective, they become non-invasive, they get reimbursed, and now they start getting pushed to second tier centers, to imaging centers, and you see the scale and the momentum starting to build. There's advocacy to add to that, and then there is now pressure. Right? Clinicians are demanding more, patients are getting more aware, and this forces now the payers to evolve as well, right? And pharma comes in at multiple stages here as the trials begin, as just various risk-based care models evolve, right? And I guess the point here is that this cascade is bound to happen. Clinical champions are being activated as we speak everywhere, right? The diagnostics are getting better, they are maturing, they're getting more accessible, and a lot of innovation still needs to happen, but that needs to happen in parallel to this push. And this push, I think, is inevitable. If you go to the next slide, let's bring this home with an example of TAVR. If you move one more slide, please, let's go straight to the TAVR example. Yes, thank you. So, one of the most successful, I would say, cardiovascular examples of our time, and this began way back 2 decades ago, maybe a little bit more, began as an experimental solution for aortic stenosis that was inoperable at the time. And now it's a mainstream, billions of dollars of therapy, widespread clinical evidence and adoption, reimbursement for payers, and very often patient-driven demand as well. And this did not happen overnight, right? I mean, this market was truly built step by step over the last couple of decades. And if you just go back, all the way in time, 2002, the very first case that happened in a human, just driven by extreme unmet need, if you will. And then the first real inflection point in 2011, when FDA approved the first valve for a narrow indication. The use case was narrow. This was for inoperable patients, but it gave the field a very strong foothold. And then the evidence started to mount, right? Whether from the partner trial, from the core valve trial, and the indication started to expand. Starting with high risk and then intermediate and eventually to low risk patients. And then the FDA approved it for favorable early risk patients. And that journey continues with recent approvals as well. And this is now a preferred therapy in many institutions and often outpacing surgical options, right? And bridge that story, arguably one of the more successful stories, and we can talk through things that didn't necessarily succeed, but bridge that with the bottom half, which is the tech adoption curve we talked about. And this is just the classic adoption curve. It's exactly what we discussed earlier. The innovators, the early adopters that led this charge, they did it long before reimbursement or scale was guaranteed, right? And it took about 15 years to truly cross the chasm, if you will. But once the evidence started to build up, the economics started to align and the confidence started to build up, the technology usually catches up, right? It moved fairly swiftly from the early stages to move to the late majority, if you will. And this wasn't luck. I mean, clearly there was a lot of concerted ecosystem effort that went into it. So the unmet need, build the data, build the ecosystem. And I think when we look at INOCA and MINOCA, with everything that we've talked about, we sort of stand at a very early adopter stage, right? The science is building, the voice of the patient is growing, the diagnostic capabilities are very real. And as further innovation happens, there isn't really a question of, is this market going to build? It is going to build. The question is, how fast is that going to happen? And what effort does it need from each one of us as stakeholders? So with that, I will end with a call to action on the next page here. And I mean, truly, if we were to unlock the promise that we've talked about and the opportunities we've talked about, we need to move as an ecosystem. I mean, this is not a game that can be played in a silo, right? This means all the clinicians here in this audience, the researchers, industry, advocacy groups, the policymakers, we come together, right? Advance the detection, accelerate the innovation, and sort of literally demand that equity in care that needs to happen. And honestly, I don't think, we don't wait for the perfect technology to come along or the perfect evidence to come along. It's clear that the patients are here, and it's very clear that the burden is so real. So I think the time is now to build this market and then to close this cardiovascular equity gap together. Thank you. Back to you, Tracy.
Wonderful. Thank you so much, Jyoti. And again, love the call to action. I think we're really trying to educate the market and talk about, how we can all address these challenges. So we have some questions from the audience I'd love to sort of pose to both of you and get your perspectives. And so I'll just jump right in. Dr. Reynolds, you mentioned one of the HARP's broader contributions is highlighting the need for earlier non-imaging based diagnostics, things like RNA-based approaches. And I know we talked about the growth in digital health and how do you see digital biomarkers like wearables and AI driven signals playing a role in this. So could maybe first Dr. Reynolds speak to how you see what advances are exciting you, or kind of what are those frontiers that we can be looking for to help address some of these challenges?
Sure. What's exciting me is that now we can finally pin down what the different phenotypes are, because it used to be that people would say, well, in theory, it could be this, it could be that, and there just wasn't a way to categorize people. So now at least we have the right diagnostics. That was true for the heart attack patients, but it was even more true for the chest pain patients. So when I first applied to American Heart Association for funding of the Minoka study, I was focused on MI in part because it was the most objective thing. And we didn't have a way of sorting the chest pain patients into diagnostic categories. So as a physician, because I see loads of these patients, I was sort of left saying, well, I know that it could be this, it could be that, and it's very hard for me to figure out which thing you have. But now, the thing's titled Inflection Point. The inflection point is we have the ability to figure out what's going on. Now we need to go one step back, or really two steps back, to be able to figure that out without getting into any of this testing. So first we need to show that we can identify the right patients to figure out who should be tested. And then we need to sort of obviate the need for this testing. So I'm excited about getting into mechanisms in detail, because along with those mechanisms, that there will come the opportunity for better diagnosis, the opportunities for personalized treatment, and then expanding that understanding into different disease states. But you mentioned wearables, and that's an area that I think is really a nice opportunity for the ambulatory chest pain patients, less so for heart attack patients, because it's a little unpredictable who will have heart attack. We'd like to predict it. But for this moment, for those patients who are walking around with these problems, I have to believe that there are signals that we can parse out about who has real heart pain and who might have another organ system affected, who needs all these other consultations.
Great. And so let's shift now to Jyoti. Given the nuanced pathophysiology and underdiagnosis of INOCA, how can you advise diagnostic developers who need to effectively quantify, communicate clinical utility and economic value for sort of payer adoption, and to differentiate from the traditional diagnostics for coronary artery disease?
Yeah, I think there is opportunity both in traditional imaging and just, bringing access to advanced imaging. And at the same time, just using the digital infrastructure we can build to just advise care pathways to avoid these fallouts in a much, much better fashion. Right. And that's really the white space that I talked about, because for most of these, and just think about what happened with Mammo, for example, with all the deep learning algorithms that help reduce false positives, that just help you make a better diagnosis. What we had to do was to prove the value, right? You prove the clinical utility, like unequivocally, and then you sort of prove the economic utility of that, and how do you actually save costs downstream by implementing that. And that sort of is what unlocks reimbursement. And we have many, many recent examples of these really smart AI algorithms, just sort of whether it is on imaging devices, off imaging devices, or using the data coming from a plethora of variables, frontline diagnostics, to just inform what the next step might be, right, to reduce cost for the care system overall. So there is tremendous opportunity there.
Great. And then maybe one more for Dr. Reynolds. Can you speak a bit to how well the updated imaging guidelines are implemented in real-world practice?
Oh, yes, they are not implemented super well. I mean, we're really in the timeline that Jyoti was talking about. We're in the chasm now. We have the right tools to make the right diagnosis. They're not available everywhere. And we need to prove the value because it's not a value in the cath lab, right? The physician who's in the cath lab has just made a diagnosis of non-obstructive disease. The economic incentive for that person in that moment is to be done with that case. When in fact, the incentive to the healthcare system is to make a complete diagnosis, because that means that patient will not be accessing a lot of other things and a lot of other imaging suites or procedure suites or trials of different medicines that aren't necessary. So we need to align the incentives a little bit to make it clear that what's best for the patient is ultimately best for the healthcare system.
Great. We have time for one final question. So Jyoti, can you speak a bit, and you did address this in your slides, sort of how do we drive awareness to the women in our lives about the risk of these conditions and to people in general?
Yeah, I think, charity begins at home. I truly believe in that. I mean, I just keep coming back to the example of breast oncology, dense breasts. I mean, this was like a groundswell of a movement for education, right? There were like a lot of that peer conversation ongoing. There were big KOLs that sort of advocated for it. Just make it the mainstream conversation, right? If you see it, you say it. Talk to your friends about it, like to engage in that conversation. And that groundswell really, really helps. I mean, I was amazed with the level of action that can be driven just with that education and that awareness. Endometriosis is another great example. Right? I mean, women suffering with symptoms for years altogether. And then that started to become a conversation. And people were like, okay, maybe that's something I want to dig into as well. Right. So I think in today's world, there isn't a lack of avenues to have the conversation. It just needs to be elevated at the right level and the messaging to be on point. What is right for the patient and why is it right for the patient and the health system, just to borrow what Dr. Reynolds just said as well.
Great. Well, I would like to thank you both so much, Dr. Reynolds and Jyoti Gera, for sharing your insights with us. And thanks to all of you for joining our Inflection Point webinar today. We will send out a recording within the next week, and we'd like to invite everyone to scan the QR code on the screen and sign up to receive invites to upcoming webinars and news from the American Heart Association Ventures. Please mark your calendars for September for our next webinar, where we'll look at the connection between migraine and cardiovascular and stroke risk. Thanks again, and have a great day.